what you're going to see is that I'm going to share information with you, but I'm not going to be a real strong proponent of one type of therapy or not. I really want to just share the information and not bias anybody in either direction. I have to be honest with you. I'm kind of agnostic myself. I see that there are times when cannabis may have a role that's positive. I see there have been times when cannabis has caused problems. And I think we need a whole lot more research, and there's so much that we don't know. So, and that's kind of what I'd like to share with you today. So in terms of our objectives, we're going to talk about the 3 different kinds of cannabinoids and a little bit about how they may or may not work. We're going to talk about 3 different routes of administration for taking medical marijuana. And then we're going to talk about 2 risks and several benefits as well. Now, this may be you. If you are currently diagnosed with cancer, you may have said to your doc or your APP or your nurses in the clinic, hey, I'm thinking about cannabis. What do you think? And you may get these very, very different kinds of responses. No, you shouldn't use cannabis. You have cancer. Or I've heard people say, yes, and I highly recommend this particular strain. Or I've had people say, and actually I'm biased, this is what I would say is the right answer. Well, tell me more about the symptoms that you're experiencing and your goals for treatment. Because there are some symptoms where cannabis seems to benefit. There are some symptoms where it seems that it doesn't help too much. And if your goal is to maintain all of your clarity and being very, very sharp, this may not be the best therapy. We kind of have to weigh the risks and benefits together. So a little history, just because I think it's extraordinarily interesting. This substance, or really it's a group of many substances, has been around for a very long time. Probably 5,000 years or more, and it may have started around the Silk Road, so Central Asia, and it spread to China and India and throughout Persia and all of that particular area. And it's been widely used medicinally, recreationally, and spiritually as well. So several religions incorporate the use of cannabis. Our more modern history with cannabis was really recorded in the middle 1800s when an Irish physician went to India to help with people in Calcutta. And he found these substances called Indian hemp. And interestingly, what was it recommended for? Pain, vomiting, seizures, and spasticity or cramping. And in the mid 1800s, around the time of our Civil War, it was actually listed in our US or United States dispensary. So it was one of the drugs that was identified as beneficial. And then in the 1800s, its use had really expanded quite widely. It was available as a tincture, so a liquid, extracts, plasters with like patches or applied as sort of a poultice, and then inhaled. And again, what was it used for? Well, everything that you wouldn't be surprised about: insomnia, sleep, headaches, appetite, sexual dysfunction, pain, whooping cough, or asthma. So that's a little history. There are 3 primary strains or types of plants that fall in the cannabis family: sativa, indica, and ruderalis. So you may have heard of hemp, which can come primarily from the sativa family, has very little THC. THC is the compound that is still considered a Schedule I narcotic in the United States, and that's federally. Of course, different states have bypassed the feds and have, legalized medical marijuana with or without THC in it. But hemp, because it has very little THC, bypasses that federal law. This was important because hemp is used in a lot of manufacturing, in ropes, in some plastics, and so to transport it across state lines would have been a federal offense. So it is approved because it has so little THC in it. Now, marijuana, medical marijuana, recreational marijuana, is higher in THC, and it comes from all three of those different families. So that's a little background. Let's talk now about the three main types of cannabinoids that you might access. So there's three broad types. The first is cannabis. This is what you get at the dispensaries. They're also called the phytocannabinoids. They come from the plant. They may or may not be synthesized into either vaping substances, inhaled substances, or gummies, or food products, or drinks. So the phytocannabinoids come from the plants themselves. There are some cannabis-based medications that have gone through the FDA process. We'll talk more about those in just a moment. And then there are your body's own cannabinoid system. We're going to talk about those in a little bit too, because that's where a lot of the excitement is right now. So back to the first group, the phytocannabinoids coming from plants. This is a picture of some of the buds, what the plants actually look like when they're harvested in the different growing areas. We have quite a few different places in Illinois under very strict regulation. Now, when you kind of break down from a chemical perspective, the cannabinoids, these phytocannabinoids, there are more than 450 different constituents, parts of the plant. That kind of makes sense. Plants are pretty complex organisms, right? So they definitely have THC. They have cannabidiol or CBD. They have cannabinol or CBN. There's also a whole group of substances called the terpenes. These are primarily found in sativa, but we don't really we don't have a good sense yet what the terpenes do. And there are probably a whole bunch of other cannabinoid type byproducts within each phytocannabinoid. So really, you're getting a lot of different substances. And I know that the dispensaries will say, oh, it's 100% this or 100% that. Not possible, really. Now, that's the first group, the phytocannabinoids. The second group are the cannabis-based medicines. Again, these are the medicines that were approved by the FDA. I'm going to be honest with you. They don't have a huge role in what we do in terms of cancer care. So there's dronabinol, which is primarily THC. It was originally released for chemotherapy-induced nausea and vomiting, but along the way, there were so much better antiemetics that were introduced, like ondansetron, which is Zofran. And so now it is only labeled for anorexia or lack of appetite associated with HIV/AIDS wasting. So it is an old drug, and because their labeling is really only for HIV/AIDS, I can run into significant problems getting this paid for. And for such an old drug, it's pretty expensive, so that's kind of disappointing. Nabilone, I haven't seen this being used clinically for more than 2 decades now. It was also released for chemo-induced nausea and vomiting before we had better agents available. Nabiximols is a combination of THC and CBD. It was approved in other countries for neuropathic pain, but it has not been approved in the United States. So it's been available in Canada for more than a decade and in many of the EU countries, again, more than a decade. And it's inhaled. It is used for, it's sprayed into the mouth, by the way, and it is used for nerve pain. Interestingly, it was originally released in Canada for people with multiple sclerosis who had terrible spasticity. These folks often experience nerve pain as well, and they started to report that this medicine provided them some relief. And then there is an agent that is strictly cannabidiol. It is, again, approved by the FDA for children who experience these very severe pediatric seizures. It's called Epidiolex. So that's the second type or form of cannabinoid products that are available. As I said, not a large influence in our clinical setting. We do have patients on dronabinol. And then there's this third category, which there's a lot of excitement about because there's a potential to manipulate our body's own internal systems. So the brain's own THC type drug is called anandamide. It binds to the body's cannabinoid receptors. And as you can see, looking at this comparison, its chemical structure is very similar to THC. So these endocannabinoids, you know, we have our body's own opioid system. Well, there's our body's own cannabinoid or endocannabinoid system, endogenous cannabinoids. And it's not surprising that these receptors are found in the frontal cortex, which is for pleasure or pain, in the basal ganglia or cerebellum, which regulates movement, and then in the hippocampus, which is a beautiful part of the brain that is involved in learning. And what do we know? We know that cannabinoids affect the pain and pleasure, our ability to move and know space and time, and sometimes our movements when we're using cannabinoids can be off a little bit. And it has been documented that when people are using cannabinoids, they have some difficulty with short-term memory. So people are looking at ways to maybe modulate the body's own cannabinoid system. And one of the enzymes involved in this is called FAAH, or the fatty acid amide hydrolase inhibitors, FAAH. These block the metabolism of our body's own endocannabinoids, making them more available. So it's in development. There's lots of labs that are looking at this. Here's an interesting story that some of you may have heard a couple years ago, just 2 years ago. It was widely reported in the New York Times, on NPR. There was this interesting woman. She was, I think, in the UK, and she remembered that she had no pain when she had a baby, and she often wondered what was wrong with her friends who were so crabby about having children. She was like, what are they complaining about? She had several traumas where she broke bones, etc., and she had no pain. She had no idea that this hurt. So it was really interesting. People were starting to, put two and two together that there's something unique about this gal. She also reported that she really never had anxiety. She never got stressed in school when her friends would get stressed about tests and stuff. She didn't get stressed when she would, as an adult, experience usual life stressors. She didn't feel any stress. She also, looking back, was pretty forgetful. She would lose items. She'd lose her train of thought mid-sentence. And these interesting scientists evaluated some of the compounds in her body and found that she had very high levels of this anandamide, the body's own THC, which means she was missing this enzyme, or had very low levels of this enzyme FAAH, as we talked about. So she wasn't breaking down the body's own endogenous cannabinoid system. So kind of excited, a lot of scientists, and so they're trying to find ways to manipulate some of these enzymes to make the body's own endocannabinoids more available, a little bit like this lady. So maybe FAAH isn't the right enzyme, since it also makes you a bit spacey and things. So others are looking at another enzyme called PEA, palmitoyl ethanolamide. I know I trip over this every time. It is an endocannabinoid. It is found in egg yolk, soybeans, peanuts, and milk. It is marketed in Europe as an anti-inflammatory. So many people are taking this as an anti-inflammatory agent to protect against aging, cancer, and pain. These are some of the usual doses, and if you go online, you're going to find a ton about this. It's even available on Amazon. Now, I'm not advocating this. We still don't have a ton of evidence and research, but it's starting to get evaluated more and more often. All right, so that's the 3 different types of cannabinoids: the phytocannabinoids, the medically developed cannabinoids, and then these endogenous cannabinoids. So when you read the results or the research, you really need to be cautious what you're reading. Are they talking about these endogenous cannabinoids? Are they talking about the phytocannabinoids? Or are they talking about the results of research related to these FDA-approved medical substances? Because quite frankly, that's where most of the research has been conducted, in the medically approved agents. So let's talk about the different routes of administration, because here's where some of you might be a little bit surprised. In some ways, certainly not necessarily for lung health, but in some ways, inhaled might be a little bit safer for some people than ingested. Here's why. So we have inhaled, and you can both smoke or you can vape. Be very, very, very careful if you decide to vape that you are getting products that have been developed by the dispensaries and not anything off the street. You may remember just a couple years ago, there were several people who ended up on ventilators because there were some clever individuals who were making their own vaped products in their own bathroom, as a matter of fact, and they were using vitamin E oil as a base. And unfortunately, the oil, when you would vape, would get into the lungs, and it was causing severe respiratory compromise for these patients. So be really, really cautious with vaping and about where you're getting the substances. So there's inhaled, there's ingested, and then there's topicals. So what do we know about each? So with inhaled, you get high bioavailability, and you get it fast. So that's why in some ways, especially for the early user, it's a little bit safer because you get blood levels in 2 to 5 minutes. You can more easily titrate. You take a puff, you start to feel something, and I have many people will tell me they'll take just 1 or 2 puffs right before bedtime, and they'll feel more relaxed and able to sleep. So it's an easier drug to titrate. It's a little bit more rapid in its onset, a little bit more predictable in its onset. People will, if they continue to smoke more than that 1 or 2 puffs, they'll get some mild euphoria, some relaxation. They may have some perceptual alterations where things seem brighter or more colorful or more dense, and ordinary experiences seem much more intense. Now, some people, especially if they're in a stressful environment, a negative environment, may feel dysphoria or sadness, concern, like a dysphoria, meaning like a anxious and an uncomfortable experience. And some people may even experience paranoia. So it's really important that you're in a good environment if you feel like you're going to be trying this for the first time. Now, what about ingested? There are so many different products. But when you swallow something, it gets into the stomach. And first of all, the metabolism gets first passed through the liver. It's got a very slow and unpredictable onset. And it can be the onset, the absorption of the drug into the bloodstream can be altered by whatever else is in the stomach. So in some ways, if you had a fatty meal, that may facilitate absorption of the drug. If you have a lot of food in the stomach that's not fatty, that may actually inhibit some of the absorption of the drug. So it's much more difficult and it's delayed. So for most people, remember, inhaled 2 to 5 minutes, ingested 2 to 5 hours. And this is what's getting people into trouble because they eat a brownie and they don't feel anything, so they have another brownie or another gummy. And this is what's actually getting people into the emergency departments. So you can't have a talk about cannabis without some of these interesting old-fashioned posters that people used to use. So to summarize this difference in absorption, the bioavailability with the oral route is much less than the inhaled route. And the time, 2 to 5 hours versus 2 to 5 minutes for inhaled. Now, what about topicals? We have no idea. There just isn't enough research. When you're rubbing the cannabis tincture on a particular area, is it getting absorbed? If so, how much is absorbed? If so, what's the delay in absorption? If you're using it orally, how much is getting absorbed? What's the delay in absorption, etc. So those are some of the challenges we have with the topical formulations. We simply do not know. And honestly, I had many patients tell me that they really got benefit from the topical cannabis. And so I asked them to bring in the formulation for me so I could just see the bottle. And it would often be labeled as CBD with menthol, 5% menthol. So 5% menthol, does that sound familiar to anybody? That's Ben Gay or Icy Hot or Vicks Vapo Rub. So rarely do I find a solution topically applied that is just the CBD. Okay, so why might we use cannabis? If you look in the literature, many different people are making many different claims about how cannabis might be beneficial. And there was an interesting paper, it's getting a little bit old now, but this came from Nora Volkow, who is the head of the National Institute of Drug Abuse. And you can see the different indications that have been listed. Glaucoma, well, it's true, it can in some cases help glaucoma, although we have now many more treatments, medical treatments that are more effective than cannabinoids. Nausea, again, we have better antiemetics, and we have identified that some people, especially people who tend to use cannabis more often, can have something called hyperemesis syndrome. They're throwing up. And how we know that this seems to be related to the cannabis, if they tell you that a hot bath or a hot shower seems to diminish that nausea and vomiting, it's likely related to the cannabinoids. We don't quite understand the mechanism. We talked about AIDS-associated wasting and anorexia may be helpful for some people. For chronic pain, people have looked at different models, different clinical, laboratory-based models of pain. It's not clear whether these are particularly helpful for pain control. An exciting area, again, is the area of inflammation. The cannabinoids seem to induce apoptosis, so rapid cell division, and it might suppress the cytokines, which would be really helpful for some autoimmune disorders like rheumatoid arthritis and Crohn's disease. So there are folks studying this in the laboratory right now, so more to come. Multiple sclerosis, we talked about how that product that's approved in Canada, nabiximols, is used for neuropathic pain and spasticity, and then the epilepsy drug that I talked about for children who have these intractable seizures. So what about the adverse effects of cannabinoids? So when people use cannabinoids, there is a potential to become dependent on the drug. It's much less than the potential for alcohol, heroin, nicotine, etc. So 9% versus 15% for alcohol or 23% for heroin. There is a withdrawal phenomenon that can occur if people are pretty consistent users of the different cannabinoids and then they stop abruptly. They will feel an irritability and anxiety. However, this is not life-threatening like withdrawal from alcohol can be for very heavy users. And when we look at the long-term and short-term effects, So for people who are just using it short term, there can be some impaired short-term memory, making it difficult to retain new information. We do worry about impaired driving. For people who use cannabinoids long-term or who are very heavy users, there is this concern about dependence and even potentially addiction. And if people are using the substance very early on, like in high school, where there is so much important learning, fundamental learning going on in our lives, there is a concern. Now, there are some studies that correlate low IQ with cannabis use. However, hard to know which came first, chicken or egg, right? Is that person who has a low IQ and not doing well at school, feeling stressed and using cannabis to cope? Or did the cannabis contribute? We really don't know. So there are some studies that suggest increased rates of motor vehicle accidents. This was a large study conducted in Colorado, Washington, and Oregon, where there had been the legislation that legalized cannabis. And these investigators compared similar states that did not have the laws at that time. So they tried to get both rural and mountainous states to emulate Colorado, Washington, and Oregon. So Nebraska, Utah, Wyoming, Idaho, and Montana. And during this time frame, they found an increase in motor vehicle accidents in the states where cannabis was legalized and a decrease in the other states. So is that actually proof? No, it's a correlation, but it's interesting. The other thing you need to know, especially if you are about my age and you grew up at a time when people were recreationally using cannabis in high school and college, it's not the same cannabis. The way it's being cultivated is that the THC potency is so much higher than it was in the 70s or 80s. And this graph ends at 2012. It's even higher now, 15, 16, 17%. In addition to the potency of the THC, so in the person who is using phytocannabinoids and they're inhaling, it's much more strong. But then there are individuals who are altering and synthesizing the cannabis down to something that's like an extract. As you can see, this almost looks like brittle. In fact, they use honey oil or hash oil to extract just the THC, and the product is then called wax or shatter or butter, and people will take this little bit of this brownish kind of concentrate and they'll smoke it with a pipe. The pipe is usually called a rig, and it is super, super, super concentrated cannabis or THC. So what is the literature? What do the studies show us? Now, this was a non-cancer study. Most of the other studies I've selected for us have been related to cancer, but this was a large study where they had more than 1,000 participants. Now, this was in Australia, and what they did was to take people with chronic back pain, work-related injuries, and these people were already on opioids for their pain. And then when cannabis was added, what they found was that cannabis use was common in people with chronic non-cancer pain who had been prescribed opioids, but they found no evidence that the cannabis use improved any of the patient outcomes, like pain control or return to work or improved activity. In fact, people who used cannabis had greater pain and lower ability to manage the pain on their own. So these authors concluded that this really didn't improve their pain control. And in fact, there's some concern, does this really muddy the waters and make it more difficult for people to get better from chronic pain? There was a review looking at the use of cannabis in people with cancer, and the authors concluded more research is needed. And unfortunately, that's the finding that you're going to see in so many of these studies. Now, a lot of the research related to cannabis comes out of Israel. Part of that is because in the United States, the National Institutes of Health hasn't been funding many studies at all because THC is a class 1 controlled substance. So it's similar to heroin or PCP. If you were lucky as a researcher to get funding, you could only use the source of cannabis from one farm in Mississippi, and they were using old strains of cannabis so that it was the older, less concentrated THC. So that's why there's really not very much research in the United States. However, as our opioid epidemic has been exploding, there is more interest in funding some of these studies. So that's why more of the research is coming from other countries, and Israel has been a huge proponent of cannabinoids. So this was a study looking at cancer patients, and this was, again, a pretty large sample, almost 3,000 patients. And what they found is that people were looking for help with sleep, pain, weakness, nausea, and appetite. And they found that some patients did improve, significant numbers of patients, although some patients, about 20%, had actually stopped using cannabinoids, which suggests that it either wasn't helpful enough, maybe they couldn't afford it, or maybe they were experiencing adverse effects. But the authors concluded that for some people, it's effective, it's tolerated, and it's safe. Now, the International Association for the Study of Pain, which is a large organization of scientists and clinicians, they conducted systematic reviews. So they looked at all the literature, both in the laboratory, in human settings, in different populations, and they really concluded that the research has a lot of gaps. They're either small studies, they're not well designed, they're not blinded, which is the gold standard of different studies, and they really could not endorse general use of cannabinoids for pain control based on the existing literature, and they called for a lot more research to be done in this area. And that was for all different kinds of pain. Michael Bennett and his colleagues in Leeds in the United Kingdom conducted a systematic review specific to people with cancer, and their reviews concluded that the studies had a high risk of bias, and that in these studies, the better studies did not show a benefit. They just really were not great studies. There were a lot of dropouts, and so we need more research. So we've talked a little bit about the different types of cannabinoids, the different ways we might ingest them, either inhaled, ingested, topical, and then we just talked about some of the research. Now let's talk about some of the regulatory issues. So there are multiple states now where cannabis is approved for recreational use, medicinal use. In Illinois, you can see we are dark green, which is legal for recreational use and medical use. The lighter green is medical use only. And the orange is sort of a hybrid. And then the states with the green and dark green and light green bars are where there's some pending research or pending legislation. So you can see more and more of the country, it consists of the dark green. But what does this mean for our patients here in Illinois? So for those of you who live in Illinois, you can get a medical card if you qualify. And if I'm assuming that most of you on this call, because you're affiliated with LivingWell, you either have cancer or you have a loved one with cancer. Cancer is one of the more than 50 diagnoses. But here are some of the challenges. It still remains not approved in Wisconsin or Indiana. And it is still a federal offense. So if you are from Wisconsin or Indiana and being treated in Chicago, you cannot get a medical card. You have to live in Illinois. Secondly, if you live in Illinois, you have a medical card. You have a legitimate source of your cannabis, and you have a traffic accident or you get a ticket in Wisconsin or Indiana, there is the possibility you have taken a Schedule I controlled substances across state lines, and you can have your medicine confiscated. I have had this problem for some of my patients. They have not fortunately been, ticketed for it, but their drugs are taken away from them. You also cannot bring your cannabis supplies into the clinic or the hospital, especially if it's got THC in it. If it's pure CBD, that's okay. But because we rely on Medicare and Medicaid funding, we don't want to violate federal laws, right? So we will sign for patients, but we can't have you bring it in to the clinic or the hospital. So there's also a challenge in that because these are not FDA regulated substances, now I'm talking about the phytocannabinoids, the plant-based products that you get at the dispensaries. The FDA doesn't regulate these. So the dispensaries can kind of say whatever they want. The websites can say whatever they want. No one's really watching this. They cannot claim that it cures an illness, but they can claim that it cures the symptoms associated with an illness. So I went onto this website. Interestingly, I went onto this website a couple years ago and I checked it up again, and it's pretty much similar, but they've expanded a little bit. So if you have chronic pain, they are advocating that you try the strain called Big Bud. If you have glaucoma, you should try Pluto. If you have joint pain, you should try Purple Kush. I need to tell you that there are no studies that have been done supporting this. So if you are interested in getting a medical card in Illinois, here's what you do. First and foremost, the physician needs to certify you. Now, it used to be all done in paper. And just recently, now it's all electronic and it's done on a portal. It's very, very easy to do. The physicians are not certifying that you are going to benefit from cannabis. They are only certifying that you have one of the 50 plus illnesses that qualify. They are also stating that you are under their care, and it needs to be an established care. So that means the very first time you meet a physician, you can't get the card signed. You have to have at least 2 meetings with that physician to call it an established care. Now, more recently, by the way, the Illinois state law allows advanced practice providers, so physician assistants and nurse practitioners, to sign these cards. Unfortunately, in Northwestern system, our policy has been that it's written that APPs, advanced practice providers like NPs and PAs, cannot sign. People are working on that right now to change that, but if you go to your nurse practitioner in the clinic and ask them to sign, at least for today, they cannot sign. We're hoping very soon that will change. There are other programs through the state of Illinois. These are all conducted through the Illinois Department of Public Health, where you can take your prescription for an opioid and get cannabis. It's a pilot project. But most of our patients who are being seen in oncology continue to need opioids, so I don't find this to be a particularly helpful program. This was to help get that chronic pain patient off their opioid and onto cannabis instead. So this is a hugely growing endeavor in Illinois. The number of licensed medical cannabis dispensaries, I live downtown here, we're located, the hospital's located downtown. There's a new dispensary, it feels like every month, just within walking distance. So there are 55 as of March of this year, and just in the past few months, another 185 additional licenses have been approved. So you can see it's just expanding. The amount of sales that have been conducted in 2021 to date, $97 million. And then since the program started in November of 2015, $985 million in total retail sales. And since 2014, they started to approve the applications before they actually had the dispensaries open. But the approved applications now are more than 154,000 patients. So I wanted to just emphasize this issue of the adverse effects so that you can be very cautious. Because as my patients have been using cannabis, most are doing fine. However, I have had more than a handful end up in the emergency room. Oftentimes, there are people who tend to be a little bit more frail, maybe a little bit more older, and a well-meaning family member will give them some gummies or some other product as an edible, and they end up in the emergency department with confusion, hallucinations. And this is a study that came out of Colorado, where there were quite a few, an increase in the number of ED visits. And now we're talking, this was 2012 to 2016. So visits to the emergency room. And of these visits, at least a quarter were attributable to cannabinoids. And of those, about 9% were related to edibles. And the visits related to inhaled cannabinoids were more likely to be the hyperemesis syndrome, so the vomiting syndrome. And the visits related to the edibles were more likely to be acute psychiatric symptoms, intoxication, and cardiovascular symptoms. So just to be very clear, most people do fine, but there is the potential for some of these adverse effects. I also just want to let you know, I know people will tell me, well, I'm taking 1,000 milligrams of cannabidiol. Sure you are. Most of the dispensaries do not have the capacity to that degree and to that level of certainty tell you precisely how many milligrams of cannabidiol is in each of those gummies. And in fact, people have obtained different samples around the country and then analyzed them in their chemistry labs. And they found that really less than 17% were accurately labeled. And if you're buying this stuff over the internet, you're really not getting much of anything in most cases. So let's just kind of talk about the bottom line. What are the pros? So there are possible health benefits. For some people, they feel more relaxed, they can sleep. I've had a few people with some pain control, and some people note less cramping and spasticity. Now, I'm going to be honest with you. I follow people with more complex pain issues in the oncology clinic. But I follow about 200 people at any given time. And right now I have 2 people who have been able to get off their pain medicines with the use of cannabis. So it's not that common. But some people use it in addition to their opioid and report some benefit. The cons, the negative, is that some people hear, medical, well, it's medical. That doesn't mean that it's really analyzed, that you really know exactly what you're getting, that it's really pure. Yes, it may say CBD, but it's very hard to synthesize from a plant unless you really are working in a very sophisticated pharmaceutical plant to be able to really extract just one compound. And so there have been some interesting legal cases, sometimes with custody issues where, dad says, hey, I'm just using CBD for pain control, and his urine toxicology shows THC and CBD. The same is true for people who are in certain work environments where they want you to do urine toxicology testing, and it will be positive for THC. So just be really careful about that. Same thing with impaired driving. And then always, always, always lock up your supplies. Some of these edibles look just like candy, and kids have taken them and gotten very sick. And there are cases where pets have gotten very sick as well. Additional considerations to think about. So what are your goals for treatment? If it's pain control, have you really fully utilized some of the other medications that we have available to us? If you're really adamant that you want to maintain very strong clarity, this may not be the right drug. It's hard to know. You may need to try it first to find out how you respond. You want to just really discuss your risks and benefits with the docs and the nurses that you work with. Again, think about if you're working, think about any negative effects on your employment. Don't bring the substances into the clinic, to the hospital. Even inpatient hospices are not able to allow people to bring in their cannabis. Now, if someone's at home, that's a different story. And then be careful, as I mentioned before, about traveling with these agents across state lines. I just want to mention that here's another example, a very clear example. This was in the New England Journal of Medicine about 2 years ago. This gentleman had a brain tumor, and he had been doing fairly well. He had just had a CT of his head. There was no real growth of the tumor. He was doing pretty well, but he was getting from a very prominent source around the country, Cresco Labs, this cannabis solution. And it was in a tiny little syringe, and he was supposed to take 0.1 milliliter, which is a couple drops, and that's what he was taking. It was 10 times the recommended therapeutic dose that we believe would have been helpful. And this guy presented to the emergency room with delirium. So of course, the first thought was, oh my gosh, is the tumor growing? It wasn't until the family brought in these agents so that the inpatient team could see what he was taking, and they could look and see that the amount was far higher than what should have been. For those of you who are really interested, this is a very easy to read book written by a palliative care doctor, where he just describes lots of these different experiences related to cannabis. So that's what I wanted to share with you. I am going to finish this.